everyone, and welcome to this webinar. Today, we're going to be talking about some research that's going on into the development of cognition and communication skills in SMA. Now, I know this is a topic that really interests a lot of members of the SMA community. So I'd like to our guests to introduce themselves. I'm sure that we all know our first guest well. Giovanni, would you like to introduce yourself?
Yeah, hi everyone. Thank you, Portia. My name is Giovanni Baranello. I'm a pediatric neurologist by training and professor of neuromuscular diseases at UCL Great Ormond Street Hospital. And I'm developing kind of interest in looking at these aspects of communication and cognition development along with our speech therapist colleagues.
And over to you, Alison.
Hi everybody. I'm Alison Felton. I'm a speech and language therapist, and I work at Alder Hey Children's Hospital, and I am the lead for neuromuscle in speech therapy there. So I treat children clinically, and I have some academic time as well at the moment. So that's all good.
An amazing lady, I'm sure.
Yeah, really.
Thank you so much for joining us. I didn't actually introduce myself. So I'm Portia Thorman, Advocacy Lead at SMA UK. And I'm also mum of a little boy who is nearly 7 now, who lives with SMA Type 1. Now, Giovanni, I really remember when we got our diagnosis, one of the first questions I asked our neurologist is, will he be cognitively able? Will he be able to speak to us? Will he be able to access mainstream school? And we were reassured that yes, and I remember her saying, children with SMA, seem to be very bright, sometimes, usually more bright than average. So what is the evidence now that's coming about? Is this still the case? If you could, tell us a little bit more about what you're finding out. That'd be really great.
Thank you, Portia. This really gives me pave the way, to share a few slides that I have prepared. Just to set up the scene of our discussion today. And these are the key points, because as you were rightly saying, even during our medical training, we have been trained with the concept that essentially SMA does not affect cognition. And actually, it's really, the daily experience that some of the individuals, the adults with SMA also, have, independent life. They even play important roles, in the day-to-day activities, and also there are some studies that have been conducted in the early ages, comparing, for example, the SMA population with other neuromuscular conditions like Duchenne muscular dystrophy, where the brain involvement, the cognitive delay, or other behavioral aspects were much more common. But now we know that much less is somehow known about how cognition develop, how social interaction, how communication, how language develop in the SMA1 treated population that is now surviving longer, and we have the possibility to interact with them, to assess them, to look after them, and to see if there is any sign that somehow deflects from what we would expect from a typically developing child. So these are all somehow points that we want to somehow reassure you about today, but also to discuss and to give you possibly some tips on what to look at here today with Alison. Just to show you, a few years ago, just anticipating somehow the fact that in a few years' time there will be a bunch of children, that will be growing and, going to school and having nearly, the normal day-to-day life. We performed this analysis of what had been published until this is dated until December 2019, and the paper has been published 2021, looking at what was the published evidence regarding brain involvement, language development, cognition development in, of course, untreated SMA1 patients. And actually, we realized that there was very little. Of course, the main reason was that these patients did not used to survive in the past, and it was impossible, to evaluate them properly, also because they were fast deteriorating, and they were very sick and very weak, so when they were at a testing age, and it was very difficult. So there was very little. But if we look, for example, at one of these papers, this is a study that essentially looked at 96 patients. 18 of them were SMA1, but if you look at the notes and the description, basically these were the strongest type 1. We can define type that they were all type 1C because they were longer survivor with later onset of the disease. And when they were compared with the non-affected siblings and also with healthy control, essentially they didn't find any difference. So their cognitive development, their intelligence was similar to their siblings and their healthy control. But potentially there were even some aspects in which they were even smarter, because all aspects that were so-called mediated by experience or by the interaction with the environment. In all these aspects, they were smarter, and when they were teenagers, they were performing even better, because probably they, what the authors were saying is that probably they had developed some adaptation, so they were performing, were adapting to the situation, and they were even better in some situations when they had grown up, compared to their siblings or their healthy control. And then we did another study also with my colleagues in Italy, specifically looking at a cohort of 22 kids with SMA1. As you see here, there is a good representation of both the more severe ones, type 1A and type 1B, and type 1C, aged between 3 and 11 years, that should have been able to communicate with a yes or a no, so that they could somehow undertake, this assessment. And these were some tests that measure essentially cognitive development. There was a test that is this ALS severity score that is developed for ALS, that looks specifically at the articulation of speech and how comprehensible, how understandable this is. Then there was a test looking more at the ability to comprehend the spoken language. And overall, we found that the general intelligence as assessed by this test and the comprehension of the language was within a normal range. What was mostly affected was the articulation and the intelligibility of speech. And this was strictly related, of course, to the severity of their global motor impairment. But that is an important point, because we adapted those tests to make them accessible to patients with a severe motor disability, because this is another bias that I will explain in a few minutes. The available tests are not specifically designed for patients with SMA or for patients with a higher level of this motor disability. And now, of course, specifically for the type 1, we are seeing that these patients have been treated, they are developing novel phenotypes. There is a lot of discussion about, how they differ, from the natural history. And although somehow the new classifications between, non-sitters, sitters, walker may somehow help, we know that a type 1 treated child who is able to sit will not be a type 2 untreated child. No, they present with a range of different comorbidities, of different problems. So although the classification somehow help, but we cannot simplify, because each child is different and will have their own needs, and they will require a particular adaptation and so on. And we don't know, if the treatments matter, if the type of treatment received matter. We still don't know if time matters. We know that time is motor neurons, so we are advocating for newborn screening in the UK. And we have seen that if we start treating the patients when they are presymptomatically, from the motor perspective, they may develop even similar to a typically developing child. But we don't know if this will also impact their overall cognition, their overall speech and communication development. And also the fact that they are becoming stronger, they are becoming more capable of doing things, they are more engaged in the usual activities, they go to the nursery, they are participating to the, day-to-day life. Is this giving different experience, a different armamentarium of things that we can build on, and so this is the question: is the nature? So is this something that we know is missing, like the SMA protein? It is important for motor neurons, or is the lack of experience and opportunities that somehow shapes the way in which they behave or they develop? And I like this example. It's like when you do this testing or you use testing that are not validated for that specific level of disability. It's like that you ask the fish to climb the tree, Of course, they will feel, stupid because you are asking something that is not adapted to their own ability. And this is what we found in that paper that I just presented. If we adapt also the testing and the way in which we look at the children, possibly we are able also to capture other strengths. It's very important to look at the environment, the social context where the child is growing, because these are all resources that we can build on to further develop and to further promote their global development. So that this is my final slide, showing that we can change from a vicious cycle of reduced experience, reduced stimuli, reduced participation, to a virtuous cycle when we can give opportunities. These children are improving in the way in which they articulate language, in which they manipulate objects, in which they make new motor milestone achievement. And of course, this needs to be in a synergistic way combined with all the possible experience and the work that our colleagues, in the community are doing with the family, the environment, with school, and so on. And I will stop sharing now.
So lots of work to be done, really, and lots of unknowns. So we don't know if it's the environment, where they've been brought up, whether it's a lack of SMN protein maybe that affects them. The testing methods possibly aren't fair. So still lots to be done by the sounds of it.
Yeah, definitely. It's a moving target, but it's important, I think, to raise the awareness in the community. Because the families are very quick at communicating each other, and we see if there are concerns, and we need to provide clear answers. And also to have a sort of proactive approach and say, we are looking at this, but there are some things that you can already start doing by looking at simple things, in your child.
Yeah. And over to you, Alison. So you're a speech and language therapist working in Alder Hey Hospital. I'm sure you have lots of information to share with our community.
Yeah, absolutely. And I will share some slides, which you should be able to see. Can you see those, Portia?
Yeah, all good.
Perfect. Okay. So like I said, I'm a speech and language therapist. I work at Alder Hey Children's Hospital. And I am the lead for neuromuscle up here, and amongst other things, and I'm doing a bit of academic work at the moment as well, and my special interest is SMA1. So hopefully I've learned something over the last couple of years while I've been doing this, but time will tell, won't it? So okay, so now there we go. Perfect. You moved it out. Should move out the way. Okay, perfect. So what I've got here is a bit of a slide. And I think sometimes if you're reading something on speech and language, it can seem like a little bit overwhelming. So I'm hoping that some of this stuff will help you while you're reading about things and talking about things, kind of come to a bit of an understanding and just get familiar with some of the words that are used about. Now, as speech therapists, we try really hard not to use jargon. We spend lots of years learning lots of jargon and then unlearning it, so that we can communicate with people, ironically. But this is kind of, I've done it this way, and this is sort of based on something from the Speech and Language UK, used to be called ICANN. And they've got some lovely resources there. And I think SMA UK are going to be putting some resources attached to this webinar, so you can have a little look at that. So, so speech sounds. So if you think about speech sounds, this first column here, so that's made of things like the muscles you need to make sounds. Okay, so how do the muscles work? Sometimes you hear the word dysarthria used, and that basically is a type of speech which results from often a weakness in muscles, and the muscles not being able to kind of get where they need to go, or they get very tired. And that's also linked to bulbar function. I know everyone says, don't they? They bandy about bulbar function is a hot topic, and I think sometimes you think, oh, actually, it's bulbar function. What does that mean? And so that it talks about the muscles are used to make sounds. Okay, and messages to the brain to make speech sounds. So that's sometimes called dyspraxia or apraxia, which is more familiar these days. And learning to use sounds to make words. So putting sounds in the right order, and how that pattern works in the language that you're being raised in, whatever language that is. If you're English or you're non-English, you know, the sounds that you use will have a pattern, and that's sometimes called phonology. Okay, so how those sounds kind of put in the right order. Okay. Next column is understanding others. So actually comprehension, sometimes that's referred to, and involves listening and attention, your auditory skills, words and concepts. So concepts can kind of be non-verbal, but actually what does that mean, and can you attach a word to it, or can you understand the word that's attached to that concept? Understanding sentences and memory. Okay, memory is important. I'm not very good at it these days, but that's something that we do need in order to remember what someone's told us in the past. Okay. Reducing language, obviously vocabulary, forming sentences, organising our sentences into something sort of coherent. So, and again, memory comes into that. What have I already said? What's going to be said? And remembering where you're up to, really, which, you know, does happen. Sometimes we'll have a bit forget what we're talking about, but, you know, in terms of our creating language, memory is really important. And using language appropriately. So pragmatic, sometimes that's referred to. And that comes down to sort of, well, you know, there's rules, isn't there, in terms of conversation? It's very difficult. We don't really know, a lot of the time, we don't acknowledge why these rules are there, but they're sometimes there, aren't they? Well, they're always there. So the fact that I might come up to say Portia and say, all right, Portia, how are you doing? And she'd say, fine, thanks, Alison. And that would be it. Now, we don't really know if Portia's fine, but that's a little sort of a dyad, a little couple of phrases that people say to each other all the time. And it's just a kind of, I don't know, how are you? I'm just checking in with you. I'm just sort of being polite. I'm acknowledging you're there kind of stuff. It kind of acknowledges a lot, but you know, I suppose when we say that, we wouldn't necessarily be saying, and how are you? And expecting to hear somebody's deepest, darkest secrets necessarily. But there's those little pairs of things. And there's just a little rule of conversation that's what you do. Generally speaking, if you ask a question, most of the time, you know, someone's waiting for a response if it's not rhetorical. So there's lots of little rules there. And that's along with your non-verbal skills that kind of we have these little rules. And they vary sometimes culturally. Things like eye contact will vary, and what's appropriate, nodding or shaking your head will vary culturally. But it can be quite confusing if someone does the opposite of what you think. Okay. So as a speech therapist, what we generally look at is all these areas when we're doing an assessment. And what I'm sort of interested in, and particularly in SMA1, is, well, is one of those things worse or lower than the others? So, and it could be any of those. So, you could be really, really good at understanding language and what's said to you. You could really, really understand that very well. But your speech sounds might be really poor. Okay, so you can have really poor speech sounds just on their own. And so, that's particularly difficult if you're trying to use a lot of language and sentences. And you've had a language burst and you've got a lot to say. Little children have a lot to say. But if your speech sounds aren't very clear, then that makes that quite difficult for the person that's trying to understand them. Alternatively,
the one that is affected by muscles in your face.
By muscles, or it's that first column. So actually, if there was an apraxic element, or actually if it was the sound patterning, the phonology, could make speech really quite unintelligible. But you're trying really hard. You know what you're going to say, but it's just not very clear.
It's not really the right thing,
Yeah, it's just not kind of getting there. Alternatively, that first column might be great. What you might say might be absolutely crystal clear and great, but you just might not say very much of it. Wow. So, you might have great speech sounds, understand what everyone's saying to you, but only have a couple of words there for some reason. Or they all might be grand, except your appropriacy of language. So you might be a right old chatterbox, but you just don't know when to not talk, or when to talk. Or when to interrupt and not interrupt, and things about being rude and politeness, which is hugely complicated. And what I'd be looking at as a speech therapist is, are these all the same developmentally, or is one or two of them particularly out of kilter with the others? And if you go for a speech and language assessment, that's what the speech therapist should be looking for. I think it's particularly important when we're looking at targeted therapy. So, lots of children don't have a lot of language, but you wouldn't necessarily target very specifically their oral motor skills, only if that was a particular problem for them. So if we go for individual assessment, that's what we'll be looking for. Are they all at the same level, or is one out of kilter with the others? And I think particularly when you get to school age, again, the educational psychologist will help with that in assessing, whether that's in line with their general level of learning or not. So there is a signs and symptoms checker in part of the resources that we've put on the webinar, so you can have another look at that if that's going to be helpful to you. And I'm hoping that this is just giving you a bit of an idea of some of the things that we kind of look for and some things to think about. Obviously, this is on the webinar, so you can come back to that slide if you want. But also, Speech and Language UK have got more detail on this. And you can kind of have a good old look and think about your own child in their own particular way, doing what they particularly want. Okay. So if we skip on, come on. Yay. Okay, fine. So when we've kind of looked at some of the studies, I think Gianni's kind of covered some of this. When we're looking particularly at bulba, so that's the muscles, and general communication outcomes, they're really not very specific, a lot of these studies. And they're often looking at something completely different. So they might be looking at, can children walk or not? And then sometimes we call it a secondary endpoint, which means it's the second thing they're looking at. But it might not even be a secondary endpoint. It might be just a tag on the end, when they were talking or they weren't talking. And it's a really kind of common thing. I think we've not found many. We've done sort of quite a systematic review over since 2010. And really, you're looking at between 10 and 15 papers with any mention of communication skills in this group, which is absolutely nothing. If you think about all the research that's, perhaps I know goes on in other kind of, types of disorders, that over that period of time is very small, particularly with the new treatments that are coming out. You'd like to think maybe I'm just nerdy because I like the speech and language side of it. But I think there's a kind of very much more on walking and motor movement than there is about communication. So that's a bit of an issue. In a lot of the studies as well, when we do a review, we actually, there's different ways of grading studies, and we call that a quality indicator. So is it strong, so high quality, medium, low quality? It's normally 3 rankings, and there's lots of different tools that researchers use to kind of look at that and grade the quality of the paper. A lot of the papers actually don't come into high quality papers at all, so those ones. So they're sort of moderate to low, although it's quite problematic because it might be a really, really good study. So it might actually be a high quality study, but just the bit about speech and language and bulbar function isn't very high quality. That's tagged on to the end. So a few of them, just as an example, they use the measurement of, a 4-year-old, can say a single word, and that would be a pass on that kind of for them. Now, obviously, 4-year-olds normally, so you're thinking about school entry, 4-year-olds should be able to say a single word. So, that's not a great measure, really. Another measure was, could the child use 2 separate vowel sounds? And again, very little babies can use 2 separate vowel sounds. So these measures are quite problematic, and I think Gianni's talked about some of the measures that they looked at, which is grand. And actually, they need to be appropriate to the group, really, and not borrowing adult assessments for very young children, which is really not very helpful either. I think. Sorry?
Lots of work to be done.
Loads, absolutely. I'm looking at about 50 years of research.
Yeah.
As Gianni said, it's a moving target as well, which makes it hard because things are changing so rapidly. I think we have some evidence that there's a strength in receptive language over expressive language. That would be a relative strength. And I think, as Gianni was saying, is it reduced experience? Is it part of the actual condition itself? We've known for many, many years in cerebral palsy that reduced life experience will reduce your communication, and lots of different kind of, and it stands to reason in itself that actually if you're not exposed to speech and language and communication, you can have a reduction in that. So actually, if you've not had a great experience, or you've been in hospital for a long time, not had the same experiences as other children, and plus we've got COVID as well at the moment, so that's not helpful. A lot of our COVID babies haven't quite had the same experience they would have had otherwise. They have talked about dysarthria, which is that weakness, so that kind of, it's almost slurred speech. That's not a surprise, I don't think, in terms of this group. So that has been noted. Also jaw opening, sometimes that's called trismus, which is another word which people have started to use. Now that comes up across other groups, so SMA3s, SMA2s, I think particularly going into adulthood. Obviously, because the children with SMA1 are still very young, we haven't really got any evidence on that at all at the moment. So we don't know the pathophysiology, which means like, why would you have jaw opening issues? I don't think we've really established that in itself. So if we don't even know why it happens, we don't know what to do about it. I think there are a number of things being used with older children, not very evidence-based, but people are just trying them to see if they work. So to try and kind of stretch the muscles around the temporomandibular joint, which is the little joint that waggles in front of your ear that makes your jaw go up and down and side to side. So that's something that you might read about if you start looking at SMA. Jaw opening might be something that's sort of mentioned, really, just to be aware of. But again, not massively. There's not a lot of evidence around that at the moment. And again, it's something else we need to look into. Fabulous. For another 10 years research. So I think one of the things I did want to talk about again is just independence, frustration, quality of life, and again getting on to alternative and augmentative communication. That will promote quality of life and independence. I think we might be talking about that a little bit later as well, but it's often called AAC, and that's using an alternative device or process. So, for example, signing, or could be using an electronic device, eye gaze device, using switches to communicate. We use all sorts. We've got talking, photograph albums, but you press a button and it says what's on the photograph, point boards, picture exchange. There's all sorts that can be used to support speech and language. And again, there's at the end, attached to the webinar, there is a resource link there for anyone who wants to go and have a look at other ways of talking. I think in terms of the research, what's interesting is obviously some of those devices are quite expensive to use if we go for those. And it's actually really hard to research what the barriers are because in different countries, they're paid for in different ways. So obviously in America, their funding system for any kind of medical device, as they would be called, would be entirely different to how that was done in the UK. So in terms of looking across countries, that's a bit problematic. But generally speaking, we use a variety of ways. We would use speech and we'd use gesture, we'd use signs, symbols, whatever the child is able to use on an individual basis. We would maximise that, really. Okay. Let's see if I can turn over. Okay, so in practice, kind of what I'm seeing at the moment is a huge variance, I have to say, in my caseload. Again, depending on the age at treatment and the presentation, so how the child was before they were treated, as well, can influence sort of what's going on with them at a later stage, really. So I have some children that talk really quite well and quite intelligibly, and then I have others who really find that quite a challenge and need quite a lot of support. And why particularly those children, I have to say we don't know. I think we're kind of assuming earlier treatment is better. We're assuming that, that's kind of going to be better, but, obviously you need to look into that more. And again, I think the other thing to sort of mention is it's not necessarily linked to swallowing, because I'm a speech and language therapist. I have to try really hard not to talk about swallowing and only to talk about communication, because that's like my main sort of thing. So I think sometimes we have children that communication skills and their swallowing skills are quite different from each other. So just because you have a deficit in one doesn't mean you'll necessarily have a deficit in another. And I think it's just quite important to say that, because actually I think if you go to a speech therapist, they potentially will also have their swallowing head on while they're assessing your child's communication. So it's worth kind of bearing that in mind. So again, we come back to individual assessment, best way forward, and see how your child's doing and get some specific advice tailored to them, really. And I think that's the end of my slides. So I'm going to stop sharing.
Thanks. It's really great. It's really great to hear just an explanation of all those words that you come across when you've been newly diagnosed, or even a little bit further down the road, like Boulder. And yeah, it's really great to have a clear explanation of what all those things mean. And you're right, because I think that sometimes in SMA, you do focus on the motor skills. And when you've got things like breathing and swallowing, which are so key to staying alive, speech and language, sometimes we don't think about until a little bit later on. So from our SMA UK family networks, we've heard about families that are concerned that their children maybe aren't talking as soon as they would have thought they would be. They like crying all the time. There's been quite a lot of that. They've noticed that they're not recognizing their own name when they think they should do, and maybe not making eye contact. And all these kinds of things are really worrying some families. Alison, I mean, we all know that any child develops at different rates. And I think when you have a child with special needs, you're hyper aware of things. So what sort of signs do you think that families should be looking for? For example, what ages should families expect their children to start talking, maybe? And if they are concerned about anything, what should they be doing?
Okay, that's a really good question. It's good. It's come from the community, so it's going to be a good question, isn't it, really? So, yeah, I think that's important to notice that all children do develop slightly differently at different rates. And I think particularly if you're anxious and looking for things, that can kind of almost put you on a bit of hyper alert to kind of different things. And obviously, if you have a child that you know is going to have special needs, that there's, you can assume that you're going to be anxious about that to some degree. So initially, the thing I think for me, people sort of talk about like a child that talks or a child that doesn't. And actually, as a speech therapist point of view, before speech happens, there's an awful lot that goes on before talking. Which is really important. So all those communication skills that I think we probably take for granted and don't really look at in a kind of not a very serious way, or we just kind of assume that we can all do it because we just learned how to do it. So things like making eye contact, the non-verbal stuff, sharing attention, and things like pointing actually is quite important. So is your child pointing towards something? Now, it may be that actually they don't have the upper limb movement ability to do that. So they might not be pointing, but the intention should be there. So I'd say sort of if your child's sort of looking towards something and maybe sort of it might be a whole hand point, it might be a reach towards something, there may be an articulation with that, there may not. And looking at you, that actually is a sign that communication is developing. So they're drawing your attention to something and you're sharing your attention on a particular item. And particularly the way to kind of look at that really is you follow what they're looking at, rather than we always try and get the children to do what we want, don't we? Look at the thing we want to talk about. And actually really we should see what they're interested, what are they looking at and what are they telling us, is sort of quite important really. If we go into sort of norms and things like that, there's lots of lovely kind of things like progress checkers and things like that, which I know we're going to be attaching to this webinar from Speech and Language UK, and they have a lovely like progress checker. So if you are worried about your child's communication skills, you can go on that progress checker and have a look and kind of see, and there's ideas on there as well. They're not specific to SMA Type 1, they are generic. However, they're still quite robust. So it's great to have a little look on there. Generally speaking, I'd say babbling about 6 to 9 months old, we should be seeing some babble. That might be varied, it might be not. So it might just be one sound, mam, 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 or changing sounds, which, is grand. We'll take both. And then they should be coming to be some sort of word in 9 to 12 months. Now, when we talk about words, these might be words that you understand as a parent and very close sort of family members kind of recognise, but it's not necessarily something that a stranger would recognise. So they might have a special word for something. So they might say bobo for bottle, for example, or I don't know. I'm thinking my nephew used to say gaga for Paddington Bear, and we never really got to the bottom of why he did that. I'm sure he'd be delighted to know now that he's nearly 30. I'm talking about him on a webinar. But so why Paddington became gaga, and he used that really regularly, really consistently for that item. So, not everyone's going to know what that word is, but as long as parents are recognising, oh yeah, that noise is a specific thing, and you should then start single words into 12 to 18 months, we should start seeing them. Now, there's a big jump then, because children, as we know, are generally fantastic and just do things sometimes without much help from us, but they don't have like a bit of a spurt. So then if we leap on to 2 years, we'd be thinking about joining 2 words together and having a vocabulary of about 50 words. Okay, so that's quite a big jump from 18 months to 2 years. If the child is using some alternatives, so if they're using sign, then they could be joining 2 signs together. If they're using speech, then it would be 2 spoken words. at that age. I think one of the things that I really try and emphasize is play, because I think it's one of those really very ordinary things that we do that actually is really quite extraordinary. And I think we cannot separate out play from language and communication. Just cognitively and developmentally, those two things are so enmeshed in each other that us saying play is one thing and communication is another is actually incredibly difficult to do. So actually play and those things that you do with your child on a regular basis are really, really super important. And there's lots of people that can kind of help out with that sort of thing. So for example, your occupational therapist, particularly if your child's had problems with access and upper limb movement, the occupational health therapist can help you with that. Or if you're very, very lucky in your area, you'll have something called portage. And portage is fabulous. And I always say to parents, if you're offered portage, grab it with both hands. It's something that's really, really fabulous. And what they do is they kind of assess your child and work on and give you ideas across the board. So not just speech and communication. They do things on motor skills, fine motor, general developmental stuff. And it's a really, really good service if it's in your area. It's not in everyone's area, I will admit. It's one of those things that I think unfortunately comes and goes. But if it's in your area and you're offered, I would be like, just give me that. I would take it. And the usual, your children's centre will have access to things like communication, play groups, parent groups, and things like that, and training for speech and language. So all those things are going to be relevant. They're not all necessarily very targeted for SMA1, but they still have a use and a place. So, and you were talking about, because that was 3 questions in one, Portia. You snuck one in there, didn't you? The other one, you're talking about what to ask for the local team, I think. So if you go to the local team for speech language, what should we be asking for? I'd be saying very much, they should be doing an individualised assessment for your child, particularly because the research we've got is indicative of potentially, having a discrepancy between different parts of speech and language. We shouldn't assume that this is all just a general developmental delay. So they should be doing an individual assessment for your child and targeting any input to those needs, really. Is the speech and language coming out at a different level to cognition generally in their general level of learning? And actually, as the child gets older, and particularly going into school and things like that, the educational psychologist will be really, really helpful, kind of helping pick out those things. And that should be something that going into school age and entering school that, would be really, really helpful to a lot of families. Again, universal services in terms of schooling, a whole language enrichment for the whole environment should be going on. And there's no reason why that shouldn't be done, because that benefits all the children in the classroom. So, a language-rich environment is only going to benefit that one child with SMA1, but it's also going to benefit everybody else as well. So there's no reason why that's not going to be a good thing for everybody. I think it'll be hard to argue against that, really, that actually we're going to have a language-poor environment. I don't think anybody would advocate for that, really. So I think that answers your question, I think.
Yeah, absolutely. And I'm glad you brought up portage, because my little boy had portage. I'd never heard of it before at all. Didn't really know what I was being offered. And because he'd been so very poorly when he was little, and we wanted to protect him from germs, and going to like mother and toddler groups and things like that weren't really an option for us. So to have someone come to our house and bring lots of wonderful resources and sing to him and play with him, and it was really great. And they also wrote up a report when he was old enough to go to nursery and turn 3, that really helped him access mainstream school as well. So it was really useful.
Fabulous, yeah. And I think it's really important, actually, if you're in a prolonged stay in hospital as well, not to undervalue the stuff that you do with your child. If you're singing and, nursery rhymes and looking at books and playing with pictures and talking about things and showing them different things, that's actually really important, all that play stuff. So that shouldn't really be devalued. You don't need for a lot of that stuff to go on, you don't need some swizzy speech therapist, although I'd say we're all fantastic. So obviously, I'm not going to downplay kind of what we do as a profession. But, in terms of parenting, that's all amazing. That's the extraordinary stuff that goes on every single day in people's homes and in, on the wards and stuff. So, that's really important.
Yeah. And I am also guilty of an over-reliance on iPads because it's very easy for a young child who doesn't have the mobility to run around and entertain themselves. Having an iPad is a really, really accessible, easy way for them to entertain themselves. So I do try to limit.
It's so difficult, isn't it? Because it's so readily available these days. That's something.
So for families where their children are getting older, finding strategies to support the communication. There's lots out there, aren't there? From eye gaze to Macathon to personal communication books. Can either of you suggest anything that has been particularly successful strategies in SMA?
So I think there's going to be one of the resources that's on which is going to be attached to this webinar is something called Different Ways of Talking. And that's produced by the Communication Trust. It's a really good little booklet. You can get it on. I call it a booklet because I'm old-fashioned, but it's online. It's an actual electronic resource. And that kind of has got lots of different things in it in terms of the choices. For a slightly old child, if you're looking for alternatives. So we refer to alternative and augmentative communication. So for children who are having difficulty speaking, this can be an alternative entirely, or there can be something that would augment their communication. So sometimes it's called AAC. You might hear of things like that. So generally speaking, I'd advocate to use a number of things at once. So just because you're using one of those things doesn't mean that you would discount everything else. So, just because you use some sort of electronic device or symbols or something like that doesn't mean that we stop talking. And I know a lot of parents kind of have sort of anxieties about, well, if we start using an alternative, are they not going to talk then? And actually really not in the SMA group, but largely in the rest of the groups, what we know is actually if you use an alternative, they are more likely to talk verbally than if you don't. Because they actually they take on all that lovely communication stuff. Their quality of life is better and they're less frustrated, and actually they want to communicate with you. So in the end, they actually talk more, some of those children, obviously within sort of their potential. So you can. So there's some very swizzy things about, and we do use these sometimes at Alder Hey. So we talk about eye gaze devices. So, and that's a device that you would use where you would look at a screen and the screen can pick up on your retina, and you can look at the screen and either pictures or letters find them, and you can communicate through the computer. And they're often seen in adults, actually. So, normally I think if you Google that, you'll often see a lot of adults who've lost the ability to talk using those sorts of things. I think you can get very, very excited about using something like that. And I have to kind of almost keep a staff calm about it. Say, it's going to be amazing. But actually, that's not necessarily the best for a lot of children. And I think we've got to take the child as an individual and in a family. A child isn't born into just a vacuum, they're born into a family. So there's going to be things that are going to be suitable for one family and child that are not going to be suitable for somebody else. I remember talking to one family talking about, sort of electronic devices that were back then hugely expensive. They're still not cheap now, but they were hugely expensive. And the mum just said to me, look, that's just not going to work for us. It's a big expensive device. And really our boys are so big, they're into sports, they throw him around, they practically use him like a rugby ball. This child is just getting so much kind of stimulation from the other siblings and stuff. It is going to be broken within, 5 minutes. And actually what he wants to say, we can figure out from something very, very simple. And that kind of managed him emotionally as well as communicationally wise. So you have to kind of take all those things kind of into consideration. Plus also, you can't take an electronic device into the shower, things like that. Or you can't, if you're, for example, me turning overnight, which some children do, if you turn them, then you have to sort out the device and get the device in front of them. Whereas actually, just like a board with yes, no, go away, is does a lot for a lot of children actually, and takes over a lot of that electronic stuff. I think in terms of other things, we talk about sign a little bit to support kind of spoken speech and language. I think I would always go for something like general gesture. I would go for something like that. And sort of nursery rhymes, and kind of certainly in the very early days, see what you get. I think it's quite difficult. I think then if you have a child that doesn't have a lot of upper limb movement, it's not necessarily going to be great for them. It wouldn't necessarily be my first choice. I'm a big advocate of sign to support speech and language. But if that might not be the correct choice for an individual child, so we kind of have to take that into account, really. So they're signs, which is what you would use with your hands, whereas a symbol would be a written tile. So, and you see these in lots of schools and things. So it's sort of like a pre-literacy thing, or you could use photographs, drawn pictures, things like that, to supplement whatever else is going on. And again, you would continue talking. And I think at the moment, it's really important to expect change and look for change, and not assume that the levels that a child is at one point is going to be the same forever. I think, we have to look with expectation is what I say to families a lot. Expect to change, look for it, and then you can support it if you see it. Whereas I think if we stop looking sometimes, we could have a chance of missing things, really. So yeah, certainly signs, symbols, electronic devices, communication books. There's picture exchange if that's appropriate for the child. There's a number of things, and actually a speech therapist will help you out with that, finding out which is going to be the most appropriate for your child, along with parents' interaction as well, skills and stuff like that. So I think that answers that one. Does it, Portia?
Yeah. Yes, it does. Thank you. So it's just really individual, I guess.
Yeah, I think it is. Yeah, I think it's fair enough, really.
Yeah. So, at the moment, we're in this sort of guinea pig generation, if you like, the SMA Type 1 family. So the children have been mainly treated post-symptomatically. Wow. Some living with complex needs. Some lucky enough to be treated a bit earlier, so living with less complex needs. But we're really hoping, as you said, Giovanni, that newborn screening is going to come to the UK as soon as possible. Do you think that will change what we're seeing in the future?
Yeah, I think that definitely yes. We know that the SMN protein is important for different organs, and I believe that there might be a role also in the brain development. So the fact that they are exposed to a possible treatment quite soon after birth, will have positive impact also on their global development. And we know that, if they develop somehow normally, in terms of, acquisition of new milestones, ability to interact and speak, this in turn will affect positively, their development. So definitely, yes. I would also, include this as one of the reasons why we should advocate, even strongly for, the implementation as quickly as possible of newborn screening programs. Because, if we see that, of course, the children who are treated when they already display some symptoms of the disease are having some delays, or they struggle a little bit, even more, it becomes important, to treat early, immediately after diagnosis, immediately after birth, actually. So definitely, I would say yes. That will be an important achievement.
Is there any way of finding out if it's SMA that's giving some children these, can I say, autistic tendencies? Is that fair? Is there any way of ever figuring that out, or will we have to wait and see what happens with newborn screening and a scientific way we figure that out?
There are, some scientists that are trying to disentangle if this is the case. There is a lot of ongoing discussion about the fact that SMA actually start before birth, and this is why, it's important that, we don't delay any any treatment, and we try to understand if the early treatment affect also brain development. There are scientists looking at the animal model, scientists looking at the other cellular models. That there is all this stuff with I don't know if you have heard about organoids, kind of trying to reproduce, at the cellular levels, how a brain look like or a spinal cord look like in the lab. So there is the ongoing work that is trying to look at that. But I think that we will need to wait a little bit to have the answers.
Yeah, that's always the answer I get. We have to wait.
Yeah.
Well, thank you. That's really interesting. And it's good to know that scientists are on it. So we at SMA UK have been thinking about the possibility of setting up a parent support network for families who are struggling to support their child's cognitive and communication development. Do you think this would be a good idea? And if so, do you think you'd be able to support a group like that in any way?
Alison, do you want to go?
Yeah, that's fine. I think it's a really good idea. I think I'd be sort of quite keen on SMA UK leading that, and kind of showing that kind of leadership and stuff. Obviously in terms of work and things, we have some sort of governance issues around that, but certainly in terms of kind of me being a resource for that, if you needed any kind of help with that, then that's kind of grand. I think probably I would think we'd need some sort of psychology input. If we're going to start looking at cognition, we'd need some psychology input into that as well. I think that would be quite valuable. So so potentially, yes, it's a great idea. Working out quite how that kind of would work and things is obviously, as always, is the problem, isn't it? But certainly.
I think that also the work that you are doing, with the new diagnosis and providing, clear and simple explanations of what you have to expect. We can probably include also, the part of monitoring, when they grow up, what are the things that Alison was mentioning that you should look at, and how you could possibly stimulate, and facilitate the progression of their development. That would be also helpful, because it is helpful for the families, especially when they go back to the sources and when they have somehow digested, the new diagnosis and the communication and all the process going through the treatment and so on. They will have more and more questions, so it's important to provide them with the right answers and where to look at.
Well, definitely.
Absolutely. And maybe that messaging at diagnosis that I got just needs to change a little bit. To say we don't really know.
Yeah. Well, absolutely.
Fantastic. Well, thank you for joining us. It's been really, really informative, and I'm sure you will have helped a lot of families out there.
Well, hopefully.
Great. Thanks so much.
Thank you.